and work on behalf of every CMH in the state and advocate for every consumer that we serve, which is hundreds of thousands of people. CMHA has been there at the beginning of the CMH movement, started in the 60s, as you know, and all the way to now. And I asked Alan if he could come today and give an update on the state of Michigan. Actually, let me reframe that. It's not the state of Michigan. The Michigan Department of Health and Human Services plan to procure out or contract out the PIHP or managed care part of Medicaid. Those that have been on listened to my presentations before understand how we're kind of structured. We'll review that now. But what we're talking about is that department desire to contract out or privatize who manages the Medicaid system. And us as CMHs right now are part of that process. We co-manage of it. And it's important to realize that without a local CMH connection to whoever the manager of care is, you lose all of your local autonomy on how services are delivered and really the services that are needed in our community. And if you've listened to some of my other discussions on this, community mental health isn't going anywhere, but our role could drastically change as a result of this. And so, Alan, I appreciate you coming today. And I know that Alan's going to run through kind of a slide deck and then a myth and fact thing that I was going to review with him. And then I'm going to add some additional comments on what I think the potential impact, again, to Ottawa County is, and then we'll answer questions. So as Alan's presenting, if you have a question, kind of write it down. We're going to wait until the end of that so that we're not going back and forth during the presentation. Okay, Alan, thank you for coming, and I'll turn it over to you.
Okay. Well, thank you very much, Dr. Brashears. Appreciate the opportunity to speak to the great folks here in Ottawa County and the greater West Michigan area. So as you can imagine, I talk about this issue all day, every day, have for the last several months. So I am going to pull up the slide deck here and run through these. And as Dr. Brashears said, we can take some questions at the end. But, I think, this kind of gives folks kind of a 10,000 foot perspective. Then we get into a little bit more detail of what actually is going on and what the Michigan Department of Health and Human Services is proposing.
And Alan, I'll just interrupt you for one moment. I'm making that distinction that it's the department doing this because our legislators are not forcing this. Nobody has told the Michigan Department of Health and Human Services to change the system. So that's why I'm like, it's a specific department doing this. It's not the state, right? I just thought I'd add that to you.
No, exactly. So again, little 10,000 foot perspective of timing of this process. So this really kind of kicked off the end of February, where the department announced through a press release that they were going to do an initiative where they're going to launch a survey, an online survey, and that the intent was that that survey was going to help direct the department as to the kind of the direction of the public mental health system. At that time, they alluded to a potential for a competitive procurement process of the state's 10 prepaid inpatient health plans. I think, as folks know, we have 10, and the acronym is PIHPs across the state, one entity per region, with all 10 regions. That survey, the window closed on March 31st. Later, a couple months later, the end of May, the department announced that the survey results are complete, that they released the survey results. Now they released very high level information. We actually, for a fact, we had to FOIA them a couple of times to actually get the the level of detail of what all the 2,600 people that responded to that survey, what those survey results were. We finally ended up getting that. And then also in their May announcement, they did announce that they intended to move forward with this procurement process. And then again, they put some detail out. On August 4th, the procurement was released where the department was putting out an RFP, a request for proposal, along with a press release that kind of went through a number of dates, and the dates are here, where they had a rate setting meeting and a bidders conference that took place on August 11th, that there was going to be vendor questions that were due by August 20th. And then that responses to those questions would come out on August 29th. Now, the department did announce last week that that was going to be pushed back a week, where that was delayed, where the responses to those questions actually should come out today by 5 o'clock. Then this also pushed out the contract, where the contract would begin on October 1 of 2026. That is now pushed back to October 6 of 2026. Again, the department anticipates to award contracts by February 24th. And again, submissions are due on September, are due now October 5th versus September 29th. Sorry, I have the wrong date on there. But from the time this RFP was released to the time that bids are due was 55 days. Which is not a long period of time. And again, they intend for these contracts to go live, 10/1 of 2026. Again.
Oh, there you go.
Oh,
Yeah. Well,
the department announced that they're going to take the current 10 PIHP regions and change it to 3 regions across the state. You see those regions there, with Ottawa County being in the central region, which I believe, if you kind of count those up, is 44 counties. It encompasses 5 current PIHP regions. And then they also take the Metro Detroit counties and bundle that into one region. It's important to note that we are not going from 10 PIHPs down to 3. The department fully intends, and we'll get into what the department director has said on this, they fully intend to award multiple entities, multiple new payers per each of these regions. So it isn't just going to be, we're going from 10 to 3, we're going from 10 to whatever number as they get bids here coming up in the next, month. They intend to have multiple payers in each of these regions.
So now let me stop you right there real quick. Can you go back one more slide? So what this practically means for us is, right now, Ottawa County is part of the Lakeshore Regional Entity that's one of the 10, and we have 4 or 5 CMHs. What this proposal will do, if it happens, is have us partner with 33 other CMHs. And instead of the citizens of Ottawa County dealing with the Ottawa CMH in one regional entity called the Lakeshore Regional Entity that manages the Medicaid, we could have Ottawa County residents having to choose between 2 or 3 different entities like health plans to manage their behavioral health stuff. And so any worldview that thinks we're shrinking the number of PIHPs to save money is wrong. In fact, you could end up with more than 10 managers, maybe not in each region, but across the board. Just wanted to highlight and add some color to that. Alan, you can continue. Thank you.
Yep. And then and put a pin in that point, because I'll touch on that here in the next couple of slides as well. There we go. So who is eligible to bid? the criteria that came out: nonprofit organizations, public governmental entities, public universities. Now, again, keep in mind here, you see my note. When we talk about nonprofit organizations, I know there's a number of nonprofit organizations that are on the Zoom right now, with the town hall. We're not talking about small mom and pop or a little bit larger nonprofit community organizations. What we're talking about are private insurance companies that under the IRS tax code are considered quote unquote nonprofit. So it's HAP, it's Priority Health, it's McLaren, it's potentially Blue Cross Blue Shield. They have a entity under their umbrella that could potentially bid for this. So again, when we talk about this idea of we are not privatizing this because it would potentially go to a nonprofit entity, that's just semantics. It's the nonprofit organizations would be private insurance companies. The board composition, the governance, some of the detail that's come out. At least a third of the governing body must consist of individuals with lived experience in the public mental health system. That is consistent with the mental health code requirements for a CMH. So Ottawa County CMH has that same requirement that at least a third of the board members have to be either what's considered primary or secondary consumers. This entity board cannot be larger than 15 members. It also is required to adhere to Open Meetings Act and FOIA. And then this is, I think, an important point that the director and others continue to hit on would be that bidders must establish and maintain governance that is entirely independent and distinct from any provider. So we've heard over and over again that there is this conflict of interest where our current PIHP boards are made up of CMH representation. So CMHs appoint the board members to the PIHP boards. Typically, a lot of times you'll see board members that sit on both the CMH board as well as the PIHP board. The department has said a number of times, as well as advocates and others, that this is a conflict of interest that shouldn't occur. And then again, that the contracting entity here must operate exclusively as a payer entity. Again, if whoever the managing entity is cannot be a provider of services.
I think
So,
it's important to recognize this relationship exists like like Priority Health and Spectrum. Spectrum delivers the service. Priority Health manages the service. They're part of the same entity, really, but that's the distinction here. And please note this 15-member board is supposed to serve 44 counties, like an unbelievable amount of counties. So right now in the current structure, Ottawa has representation to ensure that Ottawa County residents are represented at the managed care level. This would destroy that.
Yep, absolutely. So the big question, why are we doing this? So a couple of things that we pulled here from the department, directly from the director. So Director Elizabeth Hertel is the director of the Michigan Department of Health and Human Services. Michigan Medicaid beneficiaries deserve access to behavioral health services when and where they need them. The department is changing to a competitive procurement process to help create more accessible and person-centered care system of care dedicated to ensuring residents have healthier future. And this is where I wanted to put the pin in Dr. Brashears' previous comment under the 4 strategic pillars of the upcoming procurement. So the department said, why are we doing this? We want to provide high-level quality service, timely service. We want to improve choice and consistency across the regions, ensure accountability and transparency, simplify the system with reduced bureaucracy. So looking at improved choice, and if you look at a little bit further down here on the slides, that the director was on a podcast a couple of weeks ago and made this point again. When they talk about providing choice or improving choice, what the director is talking about and what the department is talking about, people want to have a choice of payer. That is what they have said. People want to have a choice of who's paying their bills. We disagree and think people really care a whole heck of a lot more about who's providing their service, who their doctor is, who their service provider is. Frankly, I don't think people could care less about who's paying the bills as long as the bills get paid on time and there's no issue there. So that again, that's number one. And as Dr. Brashears mentioned, that the department fully intends to have multiple entities per across these regions. How do you build consistency? How do you simplify a system and reduce bureaucracy or just frankly overhead if now he is dealing with one Lakeshore regional entity and in the future could be dealing with two or three different entities? Or you have a system where you could, if you look, remember the map, there's a very real scenario where you're going to have 4 or 5 payers in the Metro Detroit area because one, that's where the most of the people are, and frankly, that's where the money is at. So you could have a system where you have 4 or 5 payers in the Metro Detroit area, maybe one payer up north because there's not a whole lot of people there. There's not a big market, and then maybe 2 or 3 in the middle of the state. How does that have any kind of consistency across regions when you have all these different payers all over the place? And every entity that you bring into the mix here, you are pulling money directly out of services. Every administrative piece pulls money that goes directly into services. So the more entities that are involved here, the less dollars that are available. So again, just kind of, and we'll get in a little bit more of the myth versus facts, but just wanted to kind of touch on that point. As I mentioned, the director was on a podcast in Lansing on August 22nd, and I kind of took, so they were asking her, well, why are you doing this? What's the point? So this is directly from her. These are I summarized her quotes here, but one, she believes that this process is going to strengthen the CMH system, and we'll talk about why that's not accurate. That they are reducing the number of regions so people are able to get the services regardless of what county they live in. Again, giving people a choice of payer. That the department has listened to the concerns and took feedback from the survey in February. In that survey, people said they want more transparency and accountability. And I'll talk a minute about what people actually said from that survey. But again, that this redesign will actually add more accountability because none of the current PIHPs have advocates or persons served on their boards. This will require at least a third of those board members being primary or secondary consumers. Again, that is 100% patently false. Every single one of our PIHPs, now they are not required, they did this by choice, have individuals with lived experience on their boards. Some of them have like 50% participation on their boards. So this is 100% totally false. But again, this is the rationale that the department has been saying of why they're doing this.
I would just add something, Alan, here at this point. The reason why we have to take excerpts of what Elizabeth Hartel has said and other things is that they haven't sat down with the very CMH system that they're saying they're strengthening and talked to us about it.
No.
There's not been one meeting with the department to explain why to the very CMHs it claims to protect.
No.
So Alan has to get this information from other things. That's why he's everywhere all the time. Maybe you're omnipresent, Alan. We wish we could say, as a system, we sat down, listened to the concerns by consumers, their families, contract providers, and kind of talked it through. Alan, unless I'm wrong, that discussion has never happened.
Yep. No, I mean, what a segue. It's like, Dr. Brashears was looking at my slides ahead of time. So, as I said, I talked to lots of people about this. And again, I think, our biggest criticism of this, we have just significant concerns with the process, the manner in which the direction and how the department is carrying this out. Honestly, I think the end result, I mean, we're, maybe not 100% in disagreement with the ends, but it's how they get there is where we have the bulk of our concerns. So again, the department is doing this very much behind closed doors. This has not been an open and transparent process. I think for folks that are participating here, you probably know that this isn't the first time we've had to deal with this, and we've been dealing with this for about a 10-year or longer process. The last time in 2022, Senator Mike Shirkey, who was a Senate Majority Leader at the time, introduced legislation. And prior to that, under the Steiner administration, they had, Section 298. Both were attempts at moving the managed care piece from the public system to the private system. However, both of those were done far more transparent than what we're doing now, because those were done through the legislative process. To give Senator Shirkey credit, I mean, they had committee hearings on this. He had people in his office all the time talking about this. This was not done behind closed doors. We have a whole bunch of our members that support change, that would support improving the system. But as Dr. Brashears said, they have to be at the table. They absolutely have to be part of the solution in order to make sure the people that are receiving these services are not harmed at the end of the day. We have had one meeting. Our association, the CMHA, has had one meeting with Director Hertel since this launched in February. And frankly, it was about a 30-minute meeting. 15 minutes, we were talking about a completely different subject. Dr. Brashears is correct. There has not been a meeting where the department has gone to the CMH system and said, hey, this is what we're doing. Here's the rationale, et cetera. My next point here, the last time, the department is doing this without legislative approval, legislative oversight. To keep in mind, we were talking about taking $4.5–5 billion and changing control of that. They're doing that without legislative oversight. The last time we changed the number of PIHPs was in 2014. We went from 18 down to 10. And I actually worked for the association at that time. And they started that process in 2012. This was about a 2-year long phase in to get to the final end result. This time we're talking about 12 months, 18 months. I mean, a much shorter process. But in 2012, we literally had the department come to our office, sit down with all of our members, and they said, hey, we want, we've got concerns with the current 18 PHPs. We want to go to fewer entities. We want to do X, Y, and Z. Literally sat down with our members, and we went back and forth for several months, where we ended up, for better or worse, landed on the 10 current PIHP construction. We also consolidated what were called substance use coordinating agencies at that time. And there was some legislative boilerplate that gave the department the authority to do it at that time. This time, again, completely different process. They're totally going around the legislative process. And also keep in mind, they are doing these, when I say they, I mean the Whitmer administration, the Department of Health and Human Services. They are making these changes as they are literally walking out the door. Put this in perspective. These contracts are going into place October 1 of 2026. That is roughly 30 days before the next election for the next governor of the state of Michigan. It is 90 days before most of these people making these decisions will not be employed by the state of Michigan. They are literally, setting up the next administration, the next group coming in to fail. I mean, they are going to leave such a mess. They will not be held accountable for the decisions that they are making now in this process. I think that is just mind-blowing that they are trying to ram this through as literally they are walking out the door. And again, we'll kind of get into myths versus facts here. As I noted in the 2014 process, they could totally make any of these changes they wanted to make. The conflict of interest with PIHP boards. They want to have fewer regions. They want to do this and that. They could do all of this without a procurement process. They could have sat down, come to our office, sat down with all of our members and said, hey, 10 is too many. We want to go to 3. We want to get rid of this. We want to get rid of that. They could do all of that without going through this bid process.
I mean, they could reform the current system instead of destroying the current system.
Exactly. And again, we talk about process. We have a lot of concerns that when we talk about competitively bidding this, going to an RFP procurement process, this is totally slanted in the favor of the private sector. So a couple of reasons here. One, the public system is going to have to build a completely new vehicle or new entity to bid on this. Our current PHPs are not able to bid on this just by the way that they are constructed, though their board governance and all that. So we're going to have to create a completely new public vehicle in order to bid on this. If you're a private insurance company, you don't have to build anything new. You can use your insurance model and bid on that. When we talk about reserves, this also favors the private system where they have a section in the RFP that talks about upper limit reserves. Essentially, how much money can you hold in reserves? There is a cap. If a public entity makes a bid, the department will give them some upfront money in order to put it in reserves because essentially they're starting from zero. However, the department limits the amount of reserves that that public entity can hold moving forward. As they do now with our current PHP system, they can only hold up to 7.5% in reserves year over year. So they would put a cap on a public entity and how much money they can hold in reserves. And for what it's worth, 7.5% is roughly about 1 month's worth of services that go out the door, which is not a whole heck of a lot. However, there is no upper limit cap on the private sector, so they would not limit them whatsoever with the private entity.
That's
And then
important. That's an important distinctive, Alan. Like just to provide some Ottawa County context for those that know our county. Last year we ended the year in a deficit due to unanticipated expenditures for care. Because our region, we formed it, has a rainy day fund. That's what we're talking about. We were able to use that money to offset our deficit in this new, and then our region was only allowed to save a certain amount of the Medicaid, up to 7%. It's not much. So this is a very big issue because these new mega regions, there could be more than these payers, insurance companies could be more than one per region, can hold back dollars that could go to care more than the 7%. They could have what we call an internal service fund or rainy day fund, 10%, 15%. And so if you have 2 or 3 of them in a region, they're actually going to claw back Medicaid dollars for their rainy day fund that are really for services. And so our current system isn't perfect, but at least it tries to keep most of the money in care.
Yep.
And so I just wanted to give a little context for Ottawa folks.
Yep. No, and I mean that's a great point. And my last point here is financial liability. If this fails, who is financially responsible? Right now, I mean, there's I guess, kind of put in air quotes, a public system that shares a risk with the state of Michigan, with the Department of Health and Human Services. It appears from this RFP, the state is kind of pushing away, and that shared risk responsibility that the state currently holds potentially is not there under this new proposal that they are coming out with. And again, that upper cap limit goes a long way with who is financially responsible for this, where if you get bad Medicaid rates a couple of years in a row, we're seeing now that the amount of people that are seeking services is continuing to climb. The acuity of individuals seeking services continues to climb. If you have bad Medicaid rates, it doesn't take very long where you start operating in deficit, as Dr. Brashears has indicated. Who is ultimately responsible for that? So I mean that's certainly a big question with this as well. So some of the things, just wanted to point out what we are doing through the Community Mental Health Association. We have kind of what we've called, which Bob Sheehan, our CEO, has kind of described as a three-pronged approach. We've got our advocacy efforts where we are fighting this RFP process because we believe that it hasn't been transparent and it very much favors private sector, where we've got a whole list of allies that we're working with, the Michigan Association of Counties, a bunch of folks involved in labor, the Michigan Catholic Conference, ACLU. We've got a list of counties that's probably 30 to 35 of boards of county commissioners that have passed resolutions in opposition to this. We've got NAMI, the ARC Michigan, the Association of Children's Mental Health, all opposed to this. We've got Senator Debbie Stabenow that is opposed to this, that's working with us. So a whole host of groups. We've got action alerts out there. We've done infographics. We have September 17th at the Capitol is our annual Walk a Mile rally. We're going to do a press conference prior to that Walk a Mile rally at noon. The Walk a Mile, Senator Stabenow is going to be the keynote speaker there. That's going to begin at 1 o'clock, 1:30. So we're hoping to have several thousand people at the Michigan Capitol for that. We're working with some legislators, circulating letters, going to the governor saying, let's pull back this RFP process. Whole host of advocacy efforts that we're working on, trying to stop the RFP process. Again, we are not opposed to change, to improving the system, but again, we are very much opposed to the process. We also have legal challenges. We had a number of our members late last week, early this week, that actually filed litigation against the state, trying to prevent this RFP from continuing. And really the legal basis is on a couple of different avenues. One would be if you're a PIHP that signed the contract, which we have two that are in litigation, Midstate Health Network and Southwest Michigan Behavioral Health. Those are two of the 10 PIHPs that both sign contracts that are involved in litigation. The department cannot void an existing contract when those entities are meeting all of the conditions of the contract. They simply cannot just say, thank you very much, we're going to go and bid this out to someone else. They can only cancel those contracts if they are not fulfilling the contract obligations, which both of them are. Also, in the mental health code, it outlines you as a CMH, so Ottawa County CMH, they have the right, when going into a regional entity, they have the right to determine who they want to partner with. So right now, if Dr. Brashears wanted to say, we want to move to a different PIHP region, he'd have to get approval of the Ottawa County Board of Commissioners, but they have the ability to do that. The state cannot force a county level organization with who they must partner with. So that's kind of the basis of kind of the lawsuit that's going on currently.
If you are an individual on this Zoom that likes to read lawsuits, in our CMH website after the conclusion of this, we'll actually have attachments. You can read them. And all of the points that Alan is making are valid. The reality of the situation is we have a right as a community mental health to select our partners under the mental health code to help manage the system. And this procurement forces us to join with 33 other entities that have nothing to do with West Michigan. So just so you know, if you like reading legal challenges, I know some of you that are on the Zoom do, we will have a copy of all those lawsuits so you can read it. Now, the first 15 pages are good. The rest are attachments. There's several hundred pages, but the first 15 pages of each of those, there's two of them, really gives you the legal case for this. And so just thought I'd let you know that keeping with our level of transparency here in Ottawa, you'll have access to all of that right after the meeting.
Yep. And then the last piece of our three-pronged approach would be, well, we actually need, if the RFP continues, Well, we actually need our members to develop successful bids and bid on this so they can still be part of the managed care entities. So we are we are encouraging our members in all three of those regions to put together bids, successful bids, if the process continues. So I mean that's essentially our three-pronged approach. And then lastly, the last slide here, Dr. Brashears talked a little bit about the myth versus facts document. Just wanted to highlight a few of these things that we have heard over the last several months. That myth number one, that switching to private insurance companies or changing the PIHP structure in this fashion would eliminate layers and save costs. Because I mean, that's one of the criticisms. Well, there's too many layers to the current public mental health system. Well, one, that wasn't designed by our members. It was designed by the state of Michigan Department of Health and Human Services. But this absolutely does not replace or eliminate any layers. In fact, it eliminates the current public layer and potentially replaces it with multiple entities, multiple payers in each of those regions. And if they are private sector, private insurance companies, their overhead is anywhere between 10 and 15%, while the overhead at the Lakeshore Regional entity is about 2%. If you do the math on like $4.5 billion, you're talking potentially almost $500 million that could be pulled out of the system that doesn't go into services, that goes into higher cost, higher overhead entities that are now managing the system. Number two, that the director talked about, that they're doing this because they want to strengthen the public mental health, the CMH system, that this proposal keeps the CMH system intact. Again, we believe that is not true at all. One, it would potentially strip funding from local CMHs with the previous example of having awards go to higher overhead payers. And then two, it actually violates the mental health code in a couple of distinct fashions. So in the RFP, it talks about how the new entities shall not delegate any managed care functions to providers. So if Ottawa County CMH would be a provider, in the mental health code, it clearly states that your role as a CMH, you're required to do all this kind of stuff. In there is managing provider networks, providing oversight, contract management, things like that, all things that are considered managed care functions. So the RFP is contradicting what the mental health code allows our current CMHs to do, where they absolutely are required and have that legal role to provide those functions now.
Yeah, let me stop you right there real quick. For those that are on the Zoom, in our previous discussions, I went over the list of managed care functions. Essentially, what to remember here is that CMH right now directly provides some services, but we also manage networks to keep services going. This would reduce us to a provider of service only. Ottawa CMH would not hold the contracts to any of the service contracts we have now. That would resort, if it goes the way they've written, to this new region. So if you're a residential provider or a CLS provider or a provider of any service that we have, that you have a contract with us, I will no longer be in the business of contract management. In fact, I could be your competitor. And so it fundamentally changes the relationship between the regional entity or PHP and the CMH. We are no longer co-managing anything under this proposal. And I will simply, on the Medicaid side only, be a provider of services. And by the way, of the services I choose to provide. Mm-hmm. There'll be nothing that says I have to provide everything at all. So keep that in mind, that what's at stake is the relationship. CMHs are not going anywhere. What we do does. And I saw something in the chat about CCBHC and DCOs, to be determined. We don't know the impact of this to CCBHC and DCOs. Besides, that's moving a different direction. And currently there is no area in the procurement that addresses that, besides that the new regional entity will have to support them. So there really isn't yet a clarity on the impact on CCBHCs and if you're a DCO of that. But keep in mind, this severs the relationship between the CMH and we can only be a service provider unless they change this somehow. If they would sit down with us, we could all work it out. I just wanted to add that context.
Yep. No, very good context. And then my last point here, I already talked about the fact that they cannot force a CMH into a regional entity against their will. So certainly does not keep the current CMH system intact or strengthen it by any means. I mentioned earlier that the department's survey results indicated a demand for competitive bidding of the system management. That again is not true. We FOIA'd and had all 2,600 responses, and kind of when we broke down like a top 10, overwhelming number one was the biggest concern, and one of the questions was, what concerns do you have of the current system, and what would you like to see the department fix? Essentially, number one, overwhelmingly, workforce shortages, and specifically lack of psychiatry, and then the lack of underserved areas as far as workforce shortages. There was lack of transparency, long-term care gaps, funding inconsistencies, and client rights were really like some of the top responses of what people said. Again, this competitive procurement, changing who pays the bills, does not fix any of those issues whatsoever. Again, we continue to hear, well, the system doesn't want to change. They just want status quo. Again, 100% not accurate. I mean, when we talk about the bulk of our members, and we look at least on the CMH side, in fact, and on the provider side as well, whole bunch of them have said, yes, we support change. We would like to see change made at that current PIHP level. But again, it has to be open, it has to be transparent, has to include all stakeholders. They have to be at the table in order to do what, how are we going to address workforce shortages? How are we going to address crisis-based services, inpatient care, things like that? These folks have to be at the table in order to address those issues. So, our members certainly support change. And then lastly, we've heard over and over again that, well, the federal government is making us do this, that CMS requires competitive bidding. Again, that is not true. And in fact, we FOIA'd, again, the department, any communication between CMS and the state of Michigan regarding this procurement, there was no communication. Again, CMS has never required competitive bidding. We've been doing this since 1997. They have continued to approve what's called our sole source contracts, where the department is able to change the PIHP structure without bidding it out. Again, that has happened over and over again. There's been no indication from the federal government that they have said, yeah, we don't like that. You're going to have to competitively bid this out this time. Again, those are just some of the items that were out there on the myths versus facts. And again, the other one I think you could very easily put out there was and I mentioned this previously, the director saying, we want to move in this direction because we want to have more accountability, and that these new entities would be required to have persons served on their boards, where the current system does not. Again, all 10 PIHPs have individuals served on their boards, and in fact, some have more than 50% of individuals, either primary or secondary, on their boards.
And every CMH does as well. So we are well represented that way, and we do have, Alan put his contact information. We do have some questions in the chat that I'll go through, and then we'll open up for questions. Alan, I appreciate it's a lot to digest. You and I are living in this world all the time, so we understand every little nuance of these things, so it can be hard. But one of the questions was asked by Sue Stone. Wouldn't there be a reduction in admin costs because the number of payers would be reduced from, I think it's 46 CMHs and 10 PHP to a possible 6 payers in a central region? And I'll take a crack at it first. No, actually, it would increase administrative because all of the CMHs under the mental health code are still required to have admin functions for the general fund population, which why this doesn't make any sense. So I still have to have an access department, a utilization management department, a claims billing department. But this would require the Medicaid part of it to be done by somebody else. Right now, that's delegated to me to do it. And you could have more than one of these entities in a region. So you could have three. You could have three in the central, three in the first, three. You could have 9 or more payers. The problem is people would have to be able to pick which one of those threes they'd want to have manage it. And then CMH would have to have a relationship with all of them. Right now I have a relationship with one. So it appears when you shrink, you reduce administrative cost. My argument just changes the direction. All of the requirements are still there.
No, exactly.
And so Sue, I don't know if that answers it, but
and I think,
there really
think,
is no way.
No, and I think, I would add also all, these, if they're insurance companies or whoever, they all have different computer systems, compliance requirements. I mean, and if you're a provider, it will add administrative costs just beyond kind of the, the traditional what you think of admin costs as well. So, yeah, and again, it gets to the consistency issue where, that's going to be totally out the window. But I think this is, frankly, we're not solving any problems. We're trading whatever current issues that people may have with the current system for a whole new set of issues and concerns. And I like to, kind of flippantly say that, we're changing out. It's just a dog with different fleas. We're trading one set of problems for a whole new set of problems. And this will not reduce anything whatsoever.
And we have a lot of improvement to do if the system stays in the way it is. We need things like uniform rates, consistency on service delivery, all of the things that we're hearing. There's a way to do it without doing it this way. There was another question in the chat that might not be related to procurement, but I think for some of the providers and other folks on the Zoom call, they would appreciate an answer. So, Alan, I'll say what it is, and then you can see if this is the right venue to answer it. One was related to CCBHCs, and I kind of talked about that. Right now, we don't know the impact. But Alan says, Alan, can you speak to the email you sent out regarding the $4.56 per hour reduction to Medicaid direct care wage lines? And so I don't know if you want to talk about that. That's something I think we saw in the budget.
Yep.
And there was a reduction.
And it's really confusing. Last week, the House of Representatives put out their FY26 budget proposal, and in there, they seem to make a change regarding, over the last couple of years, there's been an increase of pay for direct care workers, and what the House put in their budget was they're going to take $215 million out of, some of those dollars that they've put into increases for direct care staff, but they are targeting it towards agencies versus individual providers. Part of the issue is it's not real consistent on who is receiving the direct care wages, because it doesn't only impact just the behavioral health side, it impacts long-term care. It's like different pockets of direct care workers were eligible to get those dollars. It appears what the House has been targeting under there's some inconsistency with providers versus when you look at like vocational and residential providers, is from my understanding of kind of who they were targeting as far as a reduction. So they want to continue to have the dollar amounts go that they put in the budget over the last couple of years, the pay to remain the same for those workers, but the amount of money that's going to be coming out would be taken out of the overhead of those agencies that employ those workers. And again, it's not the budget, long story short, we've got a long way to go in the budget process. You still have to negotiate with the Senate. You got to negotiate with the governor. Who knows if that ultimately is going to be in there? But I think the House is trying to kind of level some playing fields, and they're looking at how do we fund roads at $3 billion and some other priorities that they had. So they were looking at making some reductions. And I think from their rationale or justification, this maybe somehow level set the playing field as far as who's receiving those direct care dollars. But I don't have,
So
frankly, it's
once
not
we
very
get,
clear. I don't have a very
yeah,
good answer on it.
once we get clarity, we'll do an impact analysis and and determine what we have to do to both provide education on it and to stop it. Any reduction to providers that are providing this service administratively will be catastrophic to them. They're barely making it. One of the criticisms that we have in our current system, that's a valid one, is that not every contract with every CMH is the same, and the rates are not the same. So when you make a broad reduction like this, you can't possibly know the impact. And so once we get clarity, Alan, on that, and it becomes, if it's a real thing, we will send information out and do an impact analysis on that. And it's an important question. There was a question in the question and answer. I didn't know there was a section called that from Beth Durkee. And it says, and we talked about it a little bit, do we know what kind of reserves these companies have now? In other words, any way to guess how much they might be planning to take out of the system to fund an increased reserve?
I mean,
That's a good
it's
question.
probably hundreds of millions, if not billions of dollars in reserves. I think most insurance companies, they actually they make most of their money based off of the investments with their reserves than what they actually get from premiums that people pay. I mean, they are making hand over fist amounts of money just based off of what they hold in reserves and how they invest those reserves. But I don't know if there's a way to look and find out how much they have, but I would,
We know
be
that in some
very confident that
cases,
it's a lot.
Beth, we know it's as high as 20% from a percentage of the overall stuff with so right now we're capped at 7%, even though our PHPs cost 2%, the reserves, but like the 7% is more of the reserve, I'm sorry. But like it is, there are the point to understand, unless they change the description of this thing, there doesn't seem to be any limit or cap on how much they could take and put in reserves. And so that's interesting, because one of the biggest problems we had when we were contracting with the state, the PIHPs, to try to keep it going, is that we needed to have a little bit more of a reserve, to allowable reserve, a rainy day fund, because it's about 1 or 2 months worth of operating cost, and you can have catastrophic unintended increases in care. And to remind the community, we paid primarily by the amount of Medicaid people in our lot, in our county. But please remember, we're only serving around 8 to 10% in any given region of the Medicaid population. So we're not even funded to provide services for the Medicaid population based on any mental health prevalence rates of, what's the prevalence rate of disabilities in your county, and shouldn't you have? So we better pray that no one shows up past 8%. And so the real structural change needs to happen at how we are funding it and how we get more money and continuity. And we can deal with that without this issue. Let me see if there are any other questions in the question, answer, or the chat. I don't see any. If you have a question you'd like to ask, you can raise your hand and we can unmute you. If you go to the bottom of the controls, there's a raise hand button. I think Amanda will be able to see that and unmute you, and you can ask a question. So Amanda, let me know if anybody raises their hand.
Okay, well, I don't see anybody yet.
Okay. Sometimes we've noticed that the raise hand, Dr. Luber's just popped up. He's got his hand up. Okay, go ahead, Darren.
I unmuted myself. Can you hear me now?
Yes.
Thank you very much. Well, first, I'd just like to say great job with your presentation. I have also studied the impact from other states when we've done this, and you were right on the mark in terms of the fragmentation, the staff shortages. We also know, from, multiple great economists, let's say from like Harvard, that the capitated models do a better job containing costs and being able to provide services. And so we're going to end up with a system of care that ends up being more costly with the reduction of services. So thanks for doing the great job laying all of that out. I think you were right on the money. But my question is, how are we feeling about our legal challenges that are being set forth right now? Because it seems to me that's, and I know it might be an unfair question, but I think that's like super important that you guys are rallying a legal challenge as well as the community rallying cry that you're doing.
Yeah, the attorneys that our members are working with, I mean, they feel fairly confident that the state is violating the mental health code. I mean, it seems pretty clear and obvious that they are not following the spirit of the law, and they have asked for an expedited basically decision on, should this lawsuit if the lawsuit has merit or whatnot. So they're hoping to hear back, I think, within a pretty short period of time of, does this continue? And then I guess the big question is, if it does, how does that impact the whole timeline and timing of the RFP and all that process? But I mean, we think that, that there is some legal ground here that the state is violating the current law. And again, part of our concern that I've mentioned to a bunch of legislators, I think the sequencing of this process, again, we talked about the process, has been out of whack, where the RFP should be the last thing that happens. We absolutely know the state has to get approval from the federal government. They're going to have to change our waivers. They have not done that yet. And we believe that they're going, if they want to do what they've said in this RFP, they're going to have to change the Michigan Mental Health Code. They should get approval from the federal government and change the mental health code before they put out this RFP, have kind of all their ducks in a row, then move forward. So again, that's part of the issue as well.
Thank you.
Does that answer your question?
Absolutely. Much appreciated.
Okay, so there's a question: what ties do the people at MDHHS have? Oh, I lost it. Hold on. Have to insurance companies, and where will they be working once they leave the administration? No comment. That's all I can tell you. We can only speculate. Currently, right now, all of the people that are working at the state have previous relationships with, some of them do, with insurance companies. We don't know what their job will be afterwards. But it's an astute observation, but I can't possibly answer it. Also, as an ABA provider, these changes will not increase our ability to reach underserved clients. Correct. If anything, you'll get more of a streamlining of the benefit, and you'll have a rate compression process. The only way managed care companies can stay in existence is to deny care. That's the only way. And then invest the savings. Where at Ottawa CMH, if you've listened to my board meetings, I'm constantly saying that we can't deny service. We can't deny care. And I spend a lot of times thinking how to solve problems with inadequate funding. If I'm not part of that process, if the CMHs are not part of that process and we're just a provider, then I don't know how this works. And again, there are fair criticisms of our system. There really is. And tackling those as a group and asking for change within the existing structure is far more advantageous in solving it than this would be. This is like destroy the whole system to solve some problems that we can solve. Now, just to be honest, we as a current PIHP system and CMH system still haven't done some of the things that we wanted to do, like uniformity in audits, uniformity in contracts, uniformity in rates, uniformity in benefit. It shouldn't matter where you live. All of those things are things that we have to improve on in our current system. It was never intended to have 10 distinct regions doing whatever the hell they want. And so we're moving in that direction for some of that stuff. And if we're able to continue that, you'll actually get real change. If the CMHs are not part of that and we're just a provider, then I hope those 15 people on the new boards know what they're doing. So other questions for us? And Alan, I really appreciate you sticking around. Let's see if there's, okay, Beth answered hers. Okay, this is what I will say. Community mental health of Ottawa County, regardless of the turn of this, will remain an entity. I know a couple of presentations ago, I scared the bejesus out of everybody. And I want to be clear, we'll stay in existence. What our role will be is really the question. And my kind of slogan for this, Alan, I have a new slogan, okay, is if not 10, then 0. If we don't keep the 10 PHPs, we might as well go to 0.
Yes. Yep.
And have each CMH have an independent contract like we did for 37 years with the state to provide Medicaid and general fund services in our county. So you're going to hear me say, if not 10, then 0. If you disconnect the relationship between the CMH and these new entities to go to 3 or 2 or 1, that's not the same thing that these other bills in the past did. They kept the relationship with the CMH as a partner. This doesn't. So in the future, you're going to hear me say, if not the 10 that we have now, then 0. I don't want one non-public mega payer that has no idea what community living support services for IDD adults really means. We have a hard enough time doing it ourselves. Lots of improvement. So there's going to be the walk a mile in September. We're organizing stuff here at Ottawa CMH to provide transportation, get the word out, do some things if people want to go. And that's an opportunity for folks with their feet to say, reform the current system, don't restructure it out of existence. We're for reform, listening to the voices. People can come to my board meeting and yell at me if they want, and they can get a hold of me. Under this new arrangement, you're going to have somebody in the middle of this mega region on an 800 number. They're not going to have the same. So we're going to have some events to kind of rally. CMH of Ottawa County can't go anywhere. We're here, but our role could fundamentally change from co-managing the benefit to service provider only. And okay, that means I have no responsibility for anybody that I don't provide a service for directly. That goes away. Self-determination and self-directed care, they haven't addressed that in this procurement besides you have to do it. Well, how? At the regional level? So this is a direct threat to self-directed and self-determination care, in my opinion, until they clarify the roles and responsibilities of this entity. And Alan, you said it perfectly. They haven't even asked the federal government if they'll approve it yet. So doing all this, and CMS could be like, what are you, out of your mind? Or not. Okay. Well, and by the way, none of this is the result of the Trump reductions to Medicaid. I want to be clear. This has nothing to do with any of that. So to do this during that is even more ridiculous. We'll take any further parting questions. And if not, we'll sign off a little early.
And one point I just wanted to raise that Michael and I were chatting prior to the event starting. I mentioned I'm speaking at the Recipient Rights Conference coming up in a couple of weeks, and to Dr. Brashears' point where he's going to manage who he's going to manage and has under the mental health code recipient rights responsibilities for those folks. what happens with other entities that this new multiple entities will contract with? Where do the recipient rights, roles, and responsibilities fall in there? I mean, I think that's something that's going to fundamentally change as well.
Right, and I'm all for revisions and restructuring of our rights system so they're not necessarily as close to the CMHs, some little distance. But um, if I'm not co-managing it, if I have no responsibility for the Medicaid recipient besides if I provide a service, then I'm not going to be part of the recipient rights system at all. And I read all of them and go through them. And for some people, that might be good if it's a freestanding organization that's separate from all of this, like they have in California and other states. Okay, let's talk about it. But under this current procurement process, there are so many unanswered questions about that part of it. And Sue, you put something in the chat, says, I guess we need definition of what CMH role would be as a provider. We do too. We're seeking that. And what that would mean is we would have a contract with this regional entity to directly provide services. We do some of that now, but we don't have to have a contract with the region. We're managing it. So we would be identical to any other service provider as we understand it now.
Yep.
Subject to change and clarification.
Mhm.
But if they're not going to talk to us about it, we can't get the information.
And again, I said this earlier. Again, this is a group that's going to be walking out. They're going to make all these wide sweeping changes and then walk out the door and not going to be there to fix,
deal with the fallout.
adjust, to have the understanding of, well, what were we thinking when we wanted to do X, Y, and Z? They're gone. I mean, they're going to leave this for another group to come in and kind of have to pick up the pieces and say, what in the heck did they just do? How do we fix this? How do we move forward? Or, I mean, they could have other radical ideas and, well, let's just get rid of the whole thing. I mean, yeah, who knows where things go.
And Sue, to answer your question a little bit more specifically, it could mean, Sue, in an interesting turn of fate. And Sue, I know. So you could be coming to CMH and having us contract to provide CLS services for your child. And the region would be the one setting the rate, managing the contract. So it flips the relationship. This might be good. You'd come to me and say, Michael, we'd like to contract with you to provide X, Y, and Z. And if we provide that service, where this has the biggest impact, to my belief, is residential services, specialized residential services. If this goes the way it's written, subject to change and clarification, I would have no part in getting per person into residential, finding a placement, determining the rate. That would all be done by somebody else. That might be bad or good for some people, but at least now I'm up at night trying to solve problems with that. This goes away. It's like, well, I don't know. We'll call it Region X. Region X will have to figure that out. The contracts will be directly with the region. And we would be a contract provider for things that we directly operate. We don't directly operate residential services. They're all contracted out. Some CMHs do directly operate some residential programs, and they could decide to do that or not. But it flips the relationship. Sue, I'd be working for you under this arrangement, which, if you know Sue, she's probably chuckling right now. And she'd be saying like, yeah, and we'd get some changes done for sure. But that's the impact. And a lot of this we're just unclear on. And I'm not trying to I'm not trying to be overly dramatic. I feel it's my obligation to tell you exactly what is going on and to be as transparent. But there are other people that have a different opinion in all of this stuff. And I just think the impact is so great to us that I'm just keeping people up to date what's actually happening. And judging one way or another, like I've said in all these discussions, you can have a different view. That's fine. My job is to make sure you have information. So all of the things we talked about will be attachments on our website once we get it up. You'll have the legal suits that are out there. You'll have, Alan, your group did a great job on a flyer and myths and facts. We have that. in there. And you can look at previous discussions and see different aspects of me formally reviewing the application and the areas of this procurement in detail. So you get a sense of it. And if you're new to our group, I really appreciate you coming today and listening. And you can always reach out to me. Alan left his contact information for us in one of the slides. Alan, if you're okay, we'll put your presentation on our site and then they can
Yeah,
just
that's
click
fine.
in that.
Yep.
You know, the best way to stop this, if you want to stop it, the governor has to step in and say, Elizabeth Hotel, stop this. That's the best way. So communicating to the governor's office and saying, don't kind of reform the current structure, don't totally restructure it, is what we would say to do. We're going to do walk a mile, some other things. Some people have accused us, like, well, Alan, Michael, of course you're against this because this would, eliminate maybe your roles and jobs. I will tell you, yep, you're right. I do have a conflict of interest. I need to make sure that the citizens of Ottawa County get the services they deserve. And it's my job to ensure that and to speak against any threat. Preserve my job? Yeah, just like the fire chief wants to keep his job. We're a public service. I'm like the police chief, the fire chief. We're not a behavioral health insurance company. We're a public entity. So do I want to keep my job? You bet, Alan. Just like the police chief does and the fire chief does and the drain commissioner does, because we provide public service.
Our Article 8, Section 8 of the Michigan Constitution talks about the requirement and the role the state of Michigan shall provide these services to the people's, the citizens of the state of Michigan. So it's in the Michigan Constitution that people have the right for these
That's right.
services.
Yeah. And so, we hope that these information sessions I've been hoping are helpful to you. You can also provide comments if it's helpful or not to you, so we get a sense of it. And if we're kind of meeting the mark of it, it's really, Alan and I live and breathe this all the time. So to us, certain things make perfect sense because we understand like the 19 other things attached to it. So could CMHs be delegated for case manager services rather than direct care services? Yeah. Answer is yeah. Okay. Final thoughts, Alan, or? Oh, Rosalie has a question.
I'm wondering, how are we funding these lawsuits? I see we had a request for, is it dues for advocacy? Where is that coming from? Is that general fund or Medicaid funding? That kind of seems contradictory because I don't really agree with the lawsuits.
Sure.
And
Now, Ottawa
will there
County,
be
yeah.
more information about the lawsuit and then the attorney general about the
So-
discussions of the ISF funding that was clawed back?
Yeah, so Rosalie, Ottawa CMA, so what happened is that the Board Association asked for a special assessment, some extra funds to help pay for these things. Ottawa County actually hasn't done that. Okay, I haven't got approval to do that. Okay, but other CMHs, either using local or other funding sources, have sent small amounts to fund this. And the Board Association, through its activities and fundraising through PACs and stuff, are also using some dollars. But as of today, Ottawa County hasn't sent any additional dollars to fund these things because as a county department, I need approval from different parts of it. And I haven't gone through that. I have to go through the CMH board and the county. So it's being funded by existing funds that the Board Association already had through dues, and then a special assessment, and some CMHs have contributed to it. But it's usually no more than what you would pay annually to be part of the association. So say it cost us $2,000, we'd send $2,000. No one is sending like hundreds of thousands of dollars to do this. It's multiple buckets. I think I got that right, Alan. Is that correct?
Yep.
Or is I
Yeah. I mean, the short answer is, we are paying the legal fees through our organization, and then through, the different funding mechanisms that we have, we are covering those costs.
Yeah, and you had a second part, Rosalie, of your question. What was it?
Oh, that,
Clawbacks or something? I don't know.
oh, wait. The ISF, like the discussions with the Attorney
Yeah.
General about there was so much in reserves that the state clawed that money back.
Well, the state never took, I don't know, Alan, you want to answer that one? I think
Well,
I'm,
I don't, I know enough to be dangerous. I think
Yeah.
that she's referring to the LRE lawsuit that's
oh,
pending
ours.
regarding yes.
Yeah, and so what that is, you're correct, Rosalie, is that if it was determined that in any PIHP, current one, took more, like had more than 7% or whatever in the reserve, they would claw it back. Right. And so there was a couple of years ago, I wasn't here, that we had some excess money that we wanted to use for past debts. And we had to get permission, and we actually had a lawsuit to do that, instead of just giving that money back to the state and not solving deficits that CMHs have from past years. It's complicated because there was a period of time after COVID, they weren't settling the books annually in the normal way. There are multiple years being settled with the state at once, and it caused a lot of confusion. Right now, the PHPs can only keep 7% of any excess Medicaid that's unspent in the region, and then the rest goes back to the state, right? What the state does with it after that is really at their discretion. Sometimes 7% isn't enough to deal with unanticipated increases in care and expenditures that they have in the rainy day fund. So that was a major point when our current system was negotiating with the state. We need that percentage raised up to what we would call an actuarially sound limit, meaning we had people come in and say, you need like 11% in the region to not run out of money if you have huge changes in Kent County or Ottawa County with expenditures due to client needs. And so there was a period, Rosalie, of several years where that wasn't settled on an annual basis like it normally is. So like for our CMH last year, we ended up with the deficit. It was completely covered by the rainy day fund, which is the ISF, because it was within that 7%. So that's why we didn't have to look at additional cuts in Ottawa County to deal with an increase in expenditures that we weren't planning on, because we had that rainy day fund. So you need it to be funded correctly. So that's my best shot at answering your question, if that's what you're talking about.
Yeah, some
And-
funds have been lapsed back, but that hasn't occurred in a while. But my next comment is that LRE refused to sign the contract, the
Right.
contract with the state. How
That's right.
many regions have refused that contract? And
Half
that
of them,
should
yeah.
be discussed more too, because that was your seat at the table. So it's not,
Well, the thing is that you are correct. They stopped negotiating with all. So they said, we're done. And we were still negotiating. And one of the major contention points was on this internal service fund limit. The state just said, no. So 5 PHPs signed the contract, but had like we still got to resolve this. And then 5 said, we can't sign it with this language because we're literally not giving us enough money now. We're literally going to go out of existence in 2 years through bankruptcy, like not bankruptcy, but just running out of funding. So the majority of the PHPs weren't funded appropriately to even meet the basic needs of their regions. Only 1 or 2 of them ended up with enough money or a surplus to even put in a reserve. But yeah, we had a seat at the table, and we've heard, well, you guys walked away, so we're bidding it out. Well, we at Lakeshore signed a contract, but redlined out certain sections, saying we'll sign it if these things are future, and they said no. But they won't
Well,
even talk to
also-
us.
Also, it was the debate about conflict-free access and planning and the
Mhm.
Wasco settlement.
Right.
And those issues still need to be discussed, and I feel like that's being swept under the rug and left
got
out of
that right.
those difficult conversations, because
Yeah.
where are we with the Earned Sick Time Act, and
That's right.
where's the
All of the
funding
things
gonna
that
come
we
for
should,
that?
you are so right. All things that we should be dealing with, we can't because of this threat. It doesn't matter. All those issues is somebody else's issue besides the people that need it, right? If we're not co-managing it. So we've been diverted. I mean, Rosalie, you've been asking the same legitimate question for a while, and I have like no answer because we can't even like get information from the department. I mean, the communication is virtually stopped. It's a real interesting time. But you're 100% correct, as usual, that there are other issues that need resolving now. It's dangerous to wait. And so we're trying to get back to the business of managing. And it's really hard. Like even at the Lakeshore Regional Entity, it's really hard for them. To what degree do they put in the energy to keep resolving these things if they're going to literally be out of existence in months? And to the LRE's credit, and if you're an LRE employee on this call right now, I'm telling you, they're keeping their eye on the ball. They are handling this with honor. But it's very difficult for them to function right now when they can't even get an answer from the state on basic questions. So, yeah.
Yep.
Okay.
Yeah, very, very well said.
Yeah. We're going to go ahead and, unless there's another question, we're going to go ahead and sign off. I appreciate everybody's participation. I will be holding another one of these sessions in a couple of weeks, topic to come out at a later date. I'm hopefully going to be able to report that the state stopped this process by then. But I will keep you updated, and I very much appreciate everything everybody's doing and paying attention to this issue. And I'd like to thank Alan for being here and Amanda for keeping us on task. And